Welcome to the Quality Improvement in the NICU webinar. My name is Henry Lee, and I will be presenting on quality improvement in respiratory management in the preterm infant. After my presentation, Dr. Elizabeth Foglia will present video recording in order to improve the quality of neonatal resuscitation. Immediately following Dr. Foglia's presentation, there will be a question and answer discussion. Thank you for joining us. In terms of disclosures, in the past 2 years, I have been on the advisory board of Lantano and received research funding from Mead Johnson. So our objectives for today will be to review measurement and implementation strategies to improve outcomes for premature infants with respiratory distress disorder. We'll discuss the work of the California Perinatal Quality Care Collaborative, or CPQCC, in leveraging data and collaboration to improve NICU care. And we'll describe CPQCC's dissemination strategies for translating evidence into practice for the most vulnerable patients, including using toolkits and collaborative quality improvement principles. I put my Twitter handle there in case you want to follow along during the presentation. I will post some links to the references that I'll be mentioning during the presentation. So our California network, the CPQCC, was founded in 1997 as the first statewide perinatal collaborative. It encompasses almost all the NICUs in the state and currently includes 140 NICUs, which are of level 2, 3, and level 4 NICUs. The large majority are level 3 community NICUs. In this organization, data-driven quality improvement is performed, and the data are aligned with the Vermont-Oxford network, and additional data and eligibility criteria are made depending on the interests of the state. And there are occasionally supplemental data collections undertaken for the purpose of research or quality improvement. So the goal really is to use the data that's collected and combine it with the evidence from the literature in order to take action and improve overall quality of care in individual NICUs and across the state. This is really enacted by the volunteer members of CPQCC who form our committees. There are 4 main committees that comprise the Perinatal Quality Improvement Panel. So 3 of them are listed here. Our data committee reviews the data for opportunities for improvement regularly, and they advise on how to improve the quality reporting infrastructure, including the website where each NICU can look at their reports. Our research committee evaluates our quality improvement activities in order to help us to continuously learn in order to perform future collaborative quality improvement work. And our education committee plans our annual education meeting, as well as facilitates the development and maintenance of quality improvement toolkits. Our 4th committee, the QI Infrastructure Committee, helps to plan and execute our larger collaborative QI activities. You could see here in this figure the types of quality improvement activities that have been undertaken over the past decade or so, including one on delivery room management in 2011 to 2012. We generally follow the principles that are laid out by the Institute for Healthcare Improvement Model for Improvement. Over the years, there has been demonstrated improvement in outcomes in California NICUs for very preterm infants. So you can see here in the past decade, for our 49,000 very low birth weight infants, there has been steady improvement in survival without major morbidity. This composite measure is survival without those morbidities that are listed there, and currently, or most recently reported at 67%. So this improvement has occurred because there has been improvement in many morbidities for preterm infants. You can see here in this table that there has been significant improvement for many morbidities such as cystic periventricular leukomalacia and severe intraventricular hemorrhage. And so these numbers here, a negative number means there has been a decrease in incidence. So the larger the negative number, the better. And so particularly you can see for morbidities such as severe retinopathy, nosocomial infection, and necrotizing enterocolitis, there has been really very, very significant improvement. And I think we can be happy about those improvements. But you can see there also that for chronic lung disease, that there actually has not been a measurable overall improvement in the state for this measure of chronic lung disease, which we define as oxygen use at 36 weeks. And so I think we see there's opportunity then to work on this condition in order to improve our care for these infants. With that stability, so to speak, in terms of chronic lung disease rates, we can also note that there's large variation in this outcome across NICUs. And this is for all levels of NICU care. So here, this measure of bronchopulmonary dysplasia, chronic lung disease, or death, you can see has a lot of variation in level 2, 3, and 4 NICUs. And when we see variation, then there's opportunity for improvement. Shown in another way, this figure shows all the NICUs in California and CPQCC, each of these bars representing a NICU. And so this variation in rates can be seen here, where there are some that are performing considerably better than the average and some that are performing not as well. And therefore, if we had a situation where those NICUs that were not performing as well were able to improve their quality of care and outcomes, there's a large potential for improvement, such that if those hospitals performed at the level of the top quartile, there would be an overall statewide reduction in BPD of 25%. We can consider that chronic lung disease is a complex morbidity that has many risk factors, some which occur prior to birth, and some which we have some ability to manage and intervene and prevent. And for us, that may start with management in the delivery room, as well as our treatment of respiratory distress syndrome, or RDS. RDS is associated with survival, but also with comorbidity such as patent ductus arteriosus and necrotizing enterocolitis. And in our treatment of RDS, we can potentially have some effect on chronic lung disease by treating it well, but also not over-treating perhaps with too much invasive ventilation strategies. Randomized controlled trials have been performed and are well established that there are therapies to both prevent and treat RDS. We can consider that preventive strategies for RDS, such as antenatal steroids, may have a goal for us to have something close to 100% of preterm babies exposed to antenatal steroids in order to help prevent RDS. But in terms of the therapies, even those that have been proven to be effective, it may not be the case that all babies should receive those therapies. For example, such as CPAP or intubation, surfactants, and non-invasive administration of surfactants. All of these are good strategies that we use in order to treat RDS, but we wouldn't say that 100% of babies should receive each of these therapies, even though they have been shown to be effective. So when we consider antenatal steroids, this is a figure showing the rates of antenatal steroid administration for babies born prior to 32 weeks, or less than 1,500 grams in CPQCC. That even though there is some variation, that most NICUs tend to do reasonably well in this quality measure, achieving 90% or more in terms of the rates. But when we look at the interventions for RDS and respiratory symptoms right after birth, and this is a table showing delivery room management with application of CPAP for very preterm infants in 2020, that there are differences, first of all, by gestational age, and it doesn't approach 100%, and that's probably appropriate. So for example, for babies born less than 25 weeks gestation, the rate of CPAP in the delivery room in CPQCC was 30%, as many of those babies were ultimately intubated. For those babies born 27 to 32 weeks, the application of CPAP was 74% in the delivery room. So we can see in this table, which shows the rates of intubation in the delivery room for very preterm infants, that the converse holds true. So for the youngest infants born less than 25 weeks, the rate of intubation is 63%. And as babies get older, 27 to 32 weeks gestational age, the rate is lower at 15%. So I think what this shows us is that not every baby is going to require intubation, but we may not know the exact number. ultimately, we need to individualize treatment, perhaps partly based on gestational age and other clinical signs that might be appreciated in the delivery room. For those babies that do end up getting intubated, the Vermont-Oxford Network has published on how administering surfactant in a timely fashion within 2 hours after birth can help to improve outcomes. And so that is a quality measure that we also examine. And you can see here in this figure that that rate of surfactant within 2 hours after intubation does also vary widely across NICUs, with a median of 70%. Ultimately, we may not know the exact right number for this as well, but perhaps on the higher side is better, potentially showing that there is opportunity for improvement in this regard. And so even as we have the evidence that certain therapies are helpful to treat RDS and ultimately help potentially to prevent chronic lung disease, we can learn from quality improvement activities in order how to implement practices in order to achieve those results. Quality improvement often is a strategy that helps to standardize processes and often is concerning therapies that require a multidisciplinary effort. And certainly delivery room management as well as initial care in the NICU requires a team effort from physicians, nurses, respiratory therapists, and others. It may be also that quality improvement addresses situations where a one-size-fits-all approach may not lead to the best results. Quality improvement also helps us to learn from our experiences, and it's amenable to systems change leading to sustained results. So as we have seen the variation across our units in terms of chronic lung disease rates and respiratory management, we have the opportunity to learn from those centers that have been performing well or have learned how to improve their practice. And this is an example of a study that was published by colleagues at Cottage Hospital in Santa Barbara. And their strategy primarily centered around providing bubble CPAP soon after birth to their preterm infants. Now, that is just one part of their strategy, but using that approach, they were able to reduce their chronic lung disease rates that was at 30% and somewhat higher than the average for the state to as low as 4% as a result of their quality improvement project. This is another example of a recently published article which describes a quality improvement project performed by colleagues at Kaiser in Southern California. And in this publication, they describe how they were able to reduce their bronchopulmonary dysplasia or chronic lung disease rates in infants born prior to 33 weeks from 31% to 1.6%. I'll just briefly describe what I learned from that publication, and really they go into much more detail, so I would encourage you to look it up. But they started with this driver table of what was going to help to establish strategies in order to improve outcomes. They have a shared mental model that bronchopulmonary dysplasia is avoidable, but requires what they called aggressive preventative care. And they work to have consistent management practices to optimize chance for success. They also noted that they had a variation in even what they did for each infant. In terms of their preterm infants, they had a postnatal age-specific intervention strategy. Now, not intending to have you read this entire table, so I've highlighted some of what I consider were the key points, but I think, again, like this is really a detailed strategy that it would be worth examining potentially when you have time. But they had some strategies, including applying CPAP at a minimum for all infants in the delivery room that were born less than 28 weeks gestation, incorporate a daily round discussion of compliance with the protocol, administration of at least one surfactant dose if on the ventilator, having a low threshold for intubation and surfactant when needed, and having a standard criteria for extubation. It's also notable that even though this concerned respiratory management and outcomes, that they incorporated considerations for other aspects of NICU care as part of this. And I think it does reflect that chronic lung disease is really a multifactorial disease. So they were invested in trying to optimize antibiotic stewardship, avoiding pharmacologic treatment of reflux, postnatal steroid standardization, and fluid restriction. Ultimately, even here, I don't think a one-size-fits-all approach applies. So quality improvement in that unit may not necessarily translate exactly to the same outcomes in other units. So the local context also plays a role. But we can learn from what others have done in order to see what might fit into our units. This quality improvement approach, and I think is reflected in these articles that were just mentioned, really requires buy-in from stakeholders, all the folks that work in the NICU that care for these infants. And ultimately, it is not, again, something that is done and finished once you implement a protocol. There's a process of continual improvement and learning from what you are doing in order to have a sustainable improvement. In terms of learning from others, I think one thing that we have been able to do and are continuing to learn how to do is collaborative quality improvement. As I've shown, certain units do have better results, and therefore we can always learn from each other. And so one way that we have studied this is trying to have different strategies for quality improvement and seeing what we might be able to learn from a collaborative QI approach. So in 2011-2012, we had a quality improvement project for delivery room management in which one group, which we called the collaborative QI group, had a toolkit for delivery room management, a change package, and an expert panel that was accessible to this group. And this group met regularly, monthly, in order to report data, how they were doing in terms of the measures that we were concerned with, as well as sharing QI principles, barriers to implementation, as well as successes. And there were meetings in person as well as over the web and through email. The second group, which we called our Nicu QI group, were working on a very similar sort of strategies using the toolkit and the change package. And the difference was that they collected data but did not report it to each other. They reported it just to CPQCC. And they had local QI team meetings, but not with a larger group. So we were able to show in this delivery room management collaborative, which focused on a variety of issues in delivery room, including thermal management, so preventing hypothermia, and also decreasing invasive respiratory support, so with the goal to increase CPAP without intubating babies, and then also focusing on communication through team briefing and debriefing. And using this strategy, we compared three different groups. One was the collaborative QI group, which consisted of 20 hospitals, and then the NICU QI group, folks working on this issue, but on their own within their individual NICUs, of which there were 31 hospitals. And then there were 44 hospitals that we were able to have data on that they were collected using the same outcome measures for which they were not participating in QI activities. And this figure shows then that amongst all of these three groups, there was actually improvement in the percent of babies receiving CPAP and not intubated in the delivery room. But the collaborative quality improvement group had a more significant improvement over time that was sustained even after the project had completed. This translated into a measurable impact long-term, which those collaborative QI hospitals had reduced odds of their infants having chronic lung disease. You can see there at 0.8. So I think reflecting that there is this value to collaborating together across hospitals and learning how to improve care. We can consider again that delivery room management, especially concerning respiratory support, is one that may be improved using QI principles. It involves teamwork, complex, potentially decision-making, as well as systems of care that can be improved through working together. And just focusing in on some of these steps, which again, this is really one sort of perspective on it, that there are multiple aspects of QI that could be applied to even the first few minutes after birth. So assessing the initial need for respiratory support in a preterm infant, and when it's appropriate, early and effective application of CPAP. Requires having equipment available as well as communication and technical skills. And then for those babies requiring or benefiting from positive pressure ventilation, similarly having appropriate equipment available, having the right skills, teamwork and communication. And then for those infants who are requiring mechanical ventilation, timely surfactant administration, and continual assessment in order to provide the best care. So when we think about respiratory care in the infant right after birth, it really involves both the delivery room and the NICU. It is a continuum of care. And so this platinum hour or golden hour that has been described involves both the delivery room and initial NICU respiratory management. And so this transition perhaps is another opportunity for quality improvement. After a baby has been managed and stabilized in the delivery room, the transition to the NICU and performing the right tasks in an efficient fashion in order to provide what the baby needs, but not over-treat the patient as well, really requires a thoughtful process and potentially benefiting from quality improvement. When we have a series of tasks, procedures that are time-dependent and patient and scenario-dependent, requiring a complex set of teamwork-oriented behaviors, requiring good communication, relying on algorithms that have a stepwise approach, but also a dynamic situation, really this is a situation that can benefit from simulation and debriefing, both for training, for maintenance of skills, as well as for quality improvement. So to give some examples how simulation and debriefing can help in quality improvement processes, at our center, we have worked on using simulation to help to improve our processes during the golden hour. So in this figure on the left, you can see that we use the simulation in order to implement and simulate and practice the golden hour checklist in order to optimize care of a preterm infant transitioning from the delivery room to the NICU. So using simulation, we can not only practice, but see what aspects of our checklist as well as procedures may be improved and then iterate upon those changes. Across our state, we have also performed a quality improvement collaborative across 15 NICUs practicing in situ simulation for neonatal resuscitation. In this project, simulation has been used as a quality improvement strategy in order to discover latent safety threats and improve the overall context of care. So in summary, I hope that I've been able to show at least a little bit of how reviewing data in terms of historic data, as well as in comparison to other centers, can help us to measure processes and outcomes, ultimately helping us to improve care. And that in that process of quality improvement that we learn from within our individual centers, but also from other centers, and then ultimately there is a large benefit from collaboration and learning with others as we seek to improve care. Again, I am going to be tweeting the links to some of the references that I've mentioned during the presentation and hope to interact with you in that way. And now I will hand it off to Dr. Foglia.
Thank you, Dr. Lee, for that information about the CQPCC. I'm going to pivot and spend the next bit of time talking about video recording to improve the quality of neonatal resuscitation. By way of disclosures, I am a consultant for Medtronic. I also want to disclose that informed consent was obtained for all infants and staff who are depicted in this presentation. The objectives of this talk are to describe the role of video recording delivery room resuscitation to support quality improvement, research, and education, to recognize providers' perspectives of video-based debriefings for delivery room resuscitation, and to identify the challenges and potential benefits of applying video recording to the NICU setting. So why don't we start with the first question? Why should you think about video recording neonatal resuscitation? We just heard from Dr. Lee about the importance of golden hour management to optimize outcomes, in particular for our preterm infants. However, if you can't measure something, you can't improve it. And video recording is a powerful tool to help us measure the quality of performance in the delivery room. Delivery room documentation suffers from some significant pitfalls. It's often retrospective in nature, it's often narrative, and in particular, medical documentation does not typically capture aspects of process in the delivery room, teamwork, or help to identify systems level problems. The accuracy of real-time documentation leaves much to be desired. Claire Fishman was an undergraduate student when she performed this study. She used a video recording audit to understand the completeness and accuracy of documentation for 50 preterm infants. As you can see, for the vital signs, including the first heart rate at minute of life 5, and oxygen saturation at minute of life 5, these vital signs were both complete and accurate in numbers ranging from 68 to 90% of the records. Documentation around interventions performed in the delivery room tended to fare better. You can see that these interventions were documented appropriately in 89 to 100% of cases. And we noted that documentation tended to improve with more intensive interventions. So this is not the first setting where people have proposed to use video recording to try to improve the quality of care. This editorial was published in JAMA in 2013, where the author makes a compelling case for the utility of video to try to add some transparency and increase the completeness of our understanding of processes of care in the hospital. And in fact, I'm not the first to think of video recording in the delivery room setting. The first published record of video recording in the delivery room was actually published in the nursing literature in 1996. These authors used video recording to try to understand how providers provided stimulation and touch to preterm infants during resuscitation. 4 years later, Neil Feiner and his colleagues in San Diego published a landmark paper using video recording for delivery room resuscitation. Their methods were fairly straightforward. They used a video recording to assess 100 resuscitations, and these were graded according to a standard rubric. They found that the providers in those recordings deviated from NRP guidelines in 54% of cases. And not surprisingly, they found that errors were more likely in resuscitations where more interventions were provided. Over the ensuing 2 decades, multiple investigators and clinicians have published their experience using video recording in the delivery room for purposes related to quality improvement, research, and education. We in Pennsylvania established our video recording program in 2015. And if you'll indulge me, I'd like to just spend a bit of time talking through how it was that we established our program and how it has been used to augment our quality improvement and research and educational missions. So although we established our program in 2015, we actually started this process in 2013. It took about 2 years to get stakeholder buy-in and to establish our policy. The first process we undertook was to reach out to all of the stakeholders we could think of in the hospital setting to try to understand what value video recording might have for them, and also to try to understand their concerns and potential barriers. Not surprisingly, the biggest concern came from our legal department, and we had a lot of in-depth conversations with them about how we might use video recording in a way that would satisfy their concerns around privacy and risk while still being used for quality improvement and research in the clinical realm. So one of the issues we needed to tackle was that of privacy. We designed our policy such that anyone who had access to record or review videos had to have HIPAA training. We also posted public signs to inform the staff as well as public and any patients about the fact of our video recording program. We posted these signs in the infant resuscitation suite, in the obstetrical operating room, where we also mounted cameras. And in addition, we posted these signs in the labor and delivery registration area so that prospective parents could see them when they came in for delivery. In addition, the hospital-wide consent includes language that provides consent for video recording for quality improvement purposes. And this is actually a standard across the hospital, not specific to the delivery room. With regards to medical legal concerns, we framed our program very specifically that the videos are used for quality improvement. As such, they're protected from discovery under the Pennsylvania Peer Review Protection Act. Many states have similar statutes and acts that protect video recordings from being discoverable. As part of our policy, our video recordings are not part of the medical record. They are destroyed within 4 weeks of being recorded, and they are ultimately maintained by the Director of Audiovisual Review, who is responsible for ensuring that all videos are maintained and deleted according to this policy. With regards to the logistics of implementation, we use a web-based platform. The recordings are securely transmitted and immediately stored on the hospital server. And as the director of the program, this provides me with immense reassurance that our videos are being used and stored according to the policy. We use either a generic login through a web-based interface to start the recordings, or more recently, we've mounted a push button that can be accessed immediately in the room. The recordings can be reviewed using a password-based login through the web-based interface. However, the access to download the files is limited solely to the Director of Audiovisual Review, so that we don't have any concerns about videos being copied or transmitted outside of the scope of the policy. The web-based platform allows all videos to be deleted within 4 weeks, and this is automatically programmed. Finally, one of the features of this program is that we can annotate within the platform. So if we're interested in understanding critical information about the timing or the sequence of interventions in the delivery room, we can annotate those. And even though the videos themselves are deleted, those annotations remain as part of our database. This gives you a sense of what our video output looks like. We've mounted 2 cameras in our high-risk delivery suite. So the first is located immediately over the bed and allows us to understand the interventions that are provided to the infant. The second camera provides more of a bird's eye view, and this is really helpful for us to understand how providers are interacting in the room and the flow of providers in the room. Finally, as you can see in the bottom right corner, we have a video-based output from the vital sign monitor. And this has proved to be really helpful to understand what the patient's vital signs are and to help contextualize the interventions that are happening relative to those vital signs. I'm just going to talk for a few minutes about how we've used this program to address each of the missions that I show here. So firstly, what about quality improvement? When we started our program, I didn't have a clear idea of exactly what targets for improvement we might find, but we had a sense that we might use the videos to find areas that we could improve our process. And it didn't take long for us to see that this was in fact the case. This is a still video from the first video that we obtained with our program. As it likely occurs to you, the first thing we noticed is that there are a lot of providers touching this infant. I just want to point out a few things to you. The first is we have one provider palpating the umbilical cord to ascertain the heart rate. We have another provider auscultating the heart rate. We actually use ECG to ascertain and monitor the heart rate during our resuscitations, but we did not obtain a reliable ECG signal in this case because there was so much motion artifact. And I know that because that's actually me. I was the team leader for this resuscitation. So we started to actually look at this process in more detail and to try to understand how long was it taking us from the time that we applied the ECG leads to actually getting a reliable feed on the monitor that we could use to guide our resuscitation. And as you can see here, the median duration of time was 117 seconds, almost 2 minutes. And this is a real problem, given that NRP tells us we should be using objective vital sign monitors to obtain the heart rate, which is the single most indicator of the effectiveness of our intervention in the delivery room. So with that in mind, we undertook a process to try to implement a minimal handling protocol. This protocol applied to all of our very low birth weight infants. And our goals, as shown on the left, were really to minimize handling of our preterm infants and to quickly establish reliable vital sign recording. One of the things we noticed in our videos is even though we had allocated roles to every provider in the room, we weren't very specific about what it was we wanted that person to do in each of these roles. And so we developed a much more stereotyped and choreographed process to clearly give some guidance to each provider of exactly what was expected of them and in what sequence. Now, I recognize, especially for a global setting, that we have the benefit time that they move into this role, it's the same expectations for each delivery. We also provided some visual cues to every provider in the room of disruptions, safety and decrease or extraneous disruptions. So these were our other things of this nature. So this work has been really helpful to us to both understand, again, where are some opportunities to improve our practice, but also to provide some very tangible and real data that we can use with our leaders, as well as with our colleagues outside of neonatology, as we try to implement changes to improve the consistency and efficiency of our workflow in the delivery room setting. I want to focus now on some of the work related to using video for educational purposes. And here I'm going to highlight a study performed by Marieke den Boer. Marieke was a PhD student who was visiting us from Leiden in the Netherlands. She came to visit us at UPenn because she was very interested in understanding how providers felt and perceived video recording, and specifically video recording to facilitate team debriefings. She leveraged the fact that there was a video-based debriefing program at Leiden, and we had recently established a similar one at UPenn. And so she conducted a qualitative study of 48 providers across the two institutions. Their demographics are shown here. In general, all providers who volunteered for her study reported positive experiences with video recording. The two major domains in which they reported these experiences were firstly, the educational value. So they really emphasized that conferences to review the videos were perceived as having a high benefit for the participants. In addition, many participants verbalized that they used the videos to learn from others. And one theme that I've heard from many of my trainees is that the videos of high-risk resuscitations are a really nice way for trainees to actually increase their caseload, because they have the opportunity to watch high-risk resuscitations and to see how their colleagues successfully responded to challenging situations, and to use that information for themselves in the future as they confront similar situations. Participants also verbalized that the videos were helpful for their own assessment of their own performance. So one common theme that emerges is that many of us have impaired ability to perceive time during a high-stakes resuscitation. And the video really drives home how disparate our perception of time is from reality. In addition, many providers use the videos to help identify opportunities for them to improve their compliance with local resuscitation guidelines. Marika also asked the participants in her study to try to identify what conditions are necessary for video-based debriefings to be successful. And she thematically grouped their responses as shown here. So she found these series of 6 themes that emerged from her data. And for each theme, I'll tell you the condition and then give an example of the response that would actually fit within that from a participant. So the first is the mindset. And here, one of the respondents shared this idea that everyone in the room needs to have a shared mentality, that we were going to find opportunities to improve, and that's really the goal. The conferences need to be blame-free and shame-free. So there needs to be a safe environment to review the videos for this to be successful. We need to create involvement. All stakeholders need to be present for the reviews. And I think this really comes through that it needs to be interprofessional. It doesn't work if it's just doctors or just nurses. We need to have the same, all of the same members of the team who are in the delivery room to be represented in the conference. Participants felt that those people leading the conference need to provide information. It needs to be transparent. People need to know ahead of time that they're being video recorded and that their video recording might be used for one of these team-based debriefings. The conference should focus on benefits. Everyone, again, needs to understand that the goal is really to learn and improve. And finally, a theme that emerged was that of exposure. So many participants verbalized that the first time their video was used, there was some trepidation, but over time, as they saw their own videos and their colleagues' videos being debriefed, they became less concerned and less afraid of it. We've tried to integrate some of these lessons into our own interprofessional video review. We hold these conferences, again, with our medical team, our nursing team, our respiratory therapists, and the goal really is to review either cases where things could have gone better. Occasionally, we'll review a case that we call our exceptional cases, just to review where things went really well and to provide an opportunity for everyone to see what worked well. But these are some of the best practices that we've integrated into any of those reviews. The first is that we always start with a ground rules slide. And the goal of that slide is just to ground everyone in understanding and recognizing the goal of the conference is for improvement. It also sets some basic expectations for our participants around the type of comments that would be most useful and the type of language that would be most useful. We tend to review the video in real time with scheduled pauses for discussion. So what do I mean by that? The first time that we started our video-based debriefings, we watched the entire video in its entirety. And at the end of that, we allowed the audience or the participants to start to offer their discussion and their comments. And what we found was it was incredibly difficult for the participants to resist hindsight bias. Once they knew how the case had ended, it was very easy to go back and say, at 2 minutes, I would have done this differently. And so now we actually pause the video in real time and open it up to some very targeted questions to try to prompt all of our participants, knowing the information that we've just shown you, Now, what would you do? What are your thoughts about this case in real time? And I think that's been a very helpful way to help make sure that everyone's on the same page, and again, to help resist hindsight bias. One of the other lessons we learned is that our clinical teams really want the opportunity to reflect and to verbalize their own thoughts first. In many cases, the providers who were in the room during that resuscitation have been thinking about ways that they might have improved the process or opportunities where maybe they would have done something differently. And so recognizing that they're having these thoughts, we tend to open up the discussion to them and really allow them just to get that off their chest and to share with us already what they're thinking about how they might have improved the process. It also allows our providers to provide any context that might not be available in the video, just to help us understand, maybe there were 3 other deliveries happening at that time, or the NICU was very busy. And those are key pieces of information they want the rest of the group to understand as they watch the video. And then finally, we conclude our conference with a round of applause. And this is really just to demonstrate appreciation for our colleagues being willing to have us review their process as a way that we can all improve care. So the last few slides, I just want to talk about a new frontier. We've started, to apply video recording in the NICU. And the reason we've done this is that we really found so much benefit of our video recording program in the delivery room. We thought that we might be able to use this tool to try to identify gaps in practice in areas for opportunity for improvement in the NICU setting. So shown on the left, one of the first things we had to do was to establish some equipment to actually perform video recording in the NICU. We've mounted all of our cameras in the delivery room setting, but we have far too many beds in the NICU to do that. So we have a mobile unit that I've circled here in red. It's just a unit on wheels. It has 2 camera outputs, and that laptop is just used to integrate with the same server that I described earlier. And to start, we've really focused this video-based recording on neonatal intubation. So you can see on the right, one of the intubations that we've captured with this unit. So what are some of the lessons that we've learned so far? Well, in many cases, they're similar to the lessons we learned in the delivery room. We've noticed a lot of issues related to team dynamics and movement around the bed during intubation, and that's been helpful to us to try to start to think about stereotyped ways we might align our teams for intubation, just like we've done in the delivery room. We've also noticed problems with where our monitors and our equipment are positioned during intubation, and the fact that these are not always positioned in the same way around each bedside. So again, this is helping us think through some ways that we might standardize our equipment and the human factors of intubation. We've used the videos to identify gaps in hand hygiene. We've also identified inaccuracies in our clinical documentation, specifically around vital sign recording during intubation. It's not to say that this project is not without its challenges. Again, because this is a mobile-based trolley, we have to remember to bring it to the bedside. So it does require that there's some advanced preparation and notice so that we have time to set up the video. We also struggle with getting the camera angles correct, especially if there's a lot of people around the bed trying to figure out ways that we can actually gather the images that we need that'll be most helpful. And then we also have difficulties with our equipment. I told you that there are issues with the human factors of the clinical equipment we need. We certainly don't want our video trolley to be another barrier or an impediment to clinical care. And the last challenge that we've encountered really relates to audio input. The NICU is a noisy place, and to some degree, this program has helped us to recognize and remember just how noisy the NICU can be. But at times, it's limited our ability to use the audio feed from those videos themselves. So I'm going to wrap up here, and I just want to leave you with the following take-home points about video recording. I hope by now I may have convinced you that it is a powerful tool to assess how we deliver care in the delivery room setting. And as such, it's an important methodology to support quality improvement in research. Videos have a high potential educational value if they are used thoughtfully. And it may be possible to translate these benefits to acute care processes in the NICU. So with that, I'll thank you for your time, and my email is here. And that concludes the didactic portion of this session. We're now going to move to the Q&A portion. There is a link that you can follow, and if you follow that, that'll bring you to how you can claim your CME credits for this educational session. Thank you. Thank you for your attention. I'm here now with Dr. Henry Lee, and we're going to enter the live Q&A portion of the session. And our first question is directed to Dr. Lee regarding surfactant.
Yeah, sounds good. Thank you, Liz. Yeah, there was a question about the part where I had presented on surfactant therapy, and there was a figure showing that the surfactant administration varied quite a bit across NICUs. And the question was, why would there be withholding of surfactant at all from for a baby who's intubated, who's a premature infant with RDS, who's in the NICU? And so, so just to clarify that figure, which had showed variation across the NICUs in terms of surfactant administration rate, there was a median of 70% across NICUs, so which is relatively high, and so most babies were getting surfactant. But this was concerned babies who were intubated in the delivery room. So the definition of that quality measure is receiving of surfactant within 2 hours of after birth for those babies who are intubated in the delivery room. And so it's a good question, and I would imagine most babies in that circumstance probably would benefit from surfactant. I think there would generally be consensus about that. And so perhaps that does ultimately show there's room for improvement. Perhaps part of it is that aspect of getting it in within 2 hours, why some of those, were not categorized as receiving it because they received it later. It's also possible that there were some babies who were intubated as part of the resuscitation and ultimately may have been extubated soon after to CPAP. So some babies might fall in that category, but ultimately probably there is opportunity for quality improvement in this regard because, as the question implies, most babies in that circumstance probably should be receiving surfactant. And you want to take the next question, Liz?
Sure. Thanks, Henry. I see one question that relates to how were interruptions defined, and I think this relates to the category of flow disruptions that was grouped as interruptions. So the way this was actually defined in this study was any disruption during the resuscitation that did not directly pertain to the treatment of the patient and resulted in disruptions of the resuscitation flow. And again, the most common way that a disruption would fall in that category would be from a member of the team who was not even part of the resuscitation team coming into the resuscitation workspace and bringing something external from the resuscitation to the team that actually interrupted the flow of care that the resuscitation team was focused on at that moment. And I'll kick it back to you, Henry.
Yeah, so first, there was one question about, I had put on my Twitter account links to some of the references, but if you're not on Twitter, the presentations will be made available, as was mentioned, about a week or so from now. So those should also have a list of some of the citations. But yeah, one question that came was, what is the average length of ventilation for less than 25-week gestation infants, and what might be extubation criteria? And yeah, I can't really answer that question right now, because ultimately that's, I'm not sure if you're asking about in general across units or my specific unit, but I imagine it varies quite a bit. And I think that's probably where we can all stand to learn from each other in terms of our approaches and what might be optimal in our individual units. But I might point you to publications. There are several, including the ones I mentioned, that have worked to improve respiratory management from soon after birth all the way to trying to manage chronic lung disease and preventing chronic lung disease. And so I think those examples may be a start where you can try to consider implementing one of those in your unit and seeing how it goes and adjusting as you find appropriate in order to ultimately have various goals and measure things such as chronic lung disease rates, but also things like, what we sometimes call failed extubation, where a baby needs to be reintubated, and so adjusting those criteria, but ultimately trying to come up within your group various standardized procedures so that you can kind of work together and follow this in a systematic way.
Great. I am seeing a question from Susan Niermeyer. Hello, Susan. And it reads as follows. Staff turnover and rotation, especially from pandemic effects, have increased the challenges of coordination among members of the delivery room team. Do you have any advice on how to ameliorate this? Just-in-time pre-briefings, dedicated resuscitation team leaders, et cetera. Yeah, I think it's a really good point. It's something that I think many units grappled with even before the pandemic and even more so now. And this really gets at this idea that, you know, we often don't have a static uniform team that attends every delivery. Many of us engage in what's called teaming, which means you may have different members of the team who are coming together in different capacities, and you may or may not have worked with other members of that team in that setting before. So how do you quickly align the team in terms of roles and expectations, especially if there are members of that team who have not previously participated in a resuscitation in that specific environment? And I think some of the tools that Susan mentions are very helpful in that regard. So a just-in-time pre-briefing can be very helpful. And for us, where I showed you that minimal handling protocol, we actually have a visual aid in our high-risk resuscitation suite where we've mounted that. And it's just right there on the wall so that as we're going through our team briefing and we assign roles, we can actually use that visual aid to walk through and say, okay, here's exactly what I expect for each team member to do in their allocated role. The other way that we've actually used our videos a bit to try to help with this is in some cases, we'll use the videos as we're orienting new staff members to our NICU, because it's a helpful way for them to see one before they do one. And if we can show new staff members, you know, this is what our stereotyped process looks like. This is where you're going to be standing. This is how we're going to use the equipment that we have in our unit. In some ways, that can be a helpful adjunct to simulation or other educational tools that we might use to try to ensure that all of the team members share the same basic expectations around what's going to happen in the delivery room before they actually encounter their first clinical resuscitation, even if they're experienced providers who are maybe just new to the specific environment. Henry, shall I pass back to you?
Yeah. I might ask you a question, Liz, if that's okay.
Sure.
It seems like there's such a great benefit for education, as you're saying, from the video reviews. And how do you involve like many people across your unit to view and sort of learn together? Or is it primarily like those involved in kind of the leaders of the unit who ultimately review the videos?
It's a great question. We've tried to make the videos as accessible as possible to any of our clinical providers. And so because they're all housed on this hospital-wide server, really anyone who's in the hospital who wants to watch a video can do so. And I think the idea was to truly try to break down any barriers and to make this an accessible tool, and also to make people feel like, I think, more engaged with the methodology, that it wasn't just something that someone behind a curtain was watching without, their participation. With regards to the conferences, so we use the videos kind of in, we call them hot debriefs and cold debriefs. That the hot is sort of meant to be used right after the resuscitation. And what we'll try to do for our higher stakes resuscitations, or especially if there's any concern about the process or outcome, we'll use the videos then just to kind of quickly review with the team and use that as a way to objectively assess what happened. Because again, I think those of us who are in the room, sometimes it's difficult to maintain that objectivity. But the more formal conferences where we use the videos, we tend to just, each fellow is responsible for leading one of those. And so the fellows will actually just query the clinical providers over the last month to understand, what are some cases that we might choose to review. And then we do actually reach out to all of the clinical providers who were part of that team and engage with them before we make a decision to present their video, just because we want people, if people have a strong objection to it, we want them to have an opportunity to voice that before we, make a decision about what video the entire group is going to watch. Yeah. So I think it's 12:45. So unfortunately, we're out of time for further questions, and we thank you for your participation in joining us today.